Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Today's presenter is Dr. Prasad Katta. Dr. Katta is board certified in Internal Medicine and Endocrinology.
So let's start off. So my disclosures, I'm a speaker for Janssen Pharmaceuticals, so I just wanted to sort of go over the disclosures. So we'll just go over the definition of diabetes. So what is diabetes? It's disorder of abnormal sugar levels. And why does it happen? So it happens because of there is a decrease in insulin production, or we don't produce enough insulin, or also we don't utilize the insulin which is the body is producing properly. And insulin is a hormone made by the pancreas to regulate the blood sugars, or to control the blood sugars, or sort of balance our blood sugars, you can say. So this is a picture which shows the lifetime risk of diabetes for people born in the United States after the year 2000. Pretty much 1 in 3 Americans will have diabetes by year 2050, and it will be 1 in 2 Hispanic females and 2 out of 5 African American and Hispanics. This is according to the year 2006 statistics. So what's the prevalence of diabetes in 2000, actually this should say 2017, I apologize for that. It's about 30 million patients have type 2 diabetes. That's about almost 10% of the population, and 90% of the patients are type 2, means the other 5 to 10% are about type 1, where they need insulin from the get-go. Type 2 you can control with the oral medications, and later on you may need insulin. And there are also other drugs which are called non-insulin injectables. I'll talk about it in a little bit. And the undiagnosed are about 7.2 million people. And the one which is a serious statistic is about 85 million people have pre-diabetes. So we just talked about the diabetes, about 30 million. So almost 3 times that there are patients who are pre-diabetic, means that they probably are at a higher risk of developing diabetes than the normal population, or can develop diabetes in the next like 3 to 5 years, or even maybe at the most 10 years. So what are the risk factors for type 2 diabetes? Yes, one is inactivity. Pregnancy is a risk factor too, because the hormones makes you more insulin resistant. So then your body does not utilize your sugars well during pregnancy. Race is a risk factor. Again, as I said, Hispanics, ethnicity, African Americans, also South Asians are at a higher risk of diabetes. Hypertension is a risk factor, and a lot of patients who have diabetes also have hypertension, and it can also be vice versa. Stress is a risk factor too, but again, in most patients we can't measure stress, or in all patients we can't measure stress. So definitely that can be a risk factor. And age itself, above the age of 65 years, that's a risk factor for diabetes. The other important thing is the family history. If both parents are diabetic, the lifetime risk is as high as 60%. So if someone, say an adult who is 19 years old, both the parents are diabetic, he or she can get the risk of developing diabetes is as high as 60% in their lifetime. And also certain medications can cause. Just a cartoon which shows that obesity and type 2 diabetes. So basically the pancreas, which is the organ in the center of the belly there, saying that it's going on strike, and you see this person having soda pop in one hand and a burger or something like that in the other hand, or a hot dog in the other hand, and that's what it's saying. So the other reason for diabetes, as we described, is the lack of exercise. So we have means basically the evolution of mankind from the hunter-gatherer stage to a couch potato stage. So that's the other reason. So I'm going to next part of the talk. Most of my slides will be on medications. So I basically based the talk in medications old and new. So old, I've said anything before year 2005, I've said it as old, and the newer medications 2005 or later, because a lot of the newer medications have helped to control the diabetes better in the long run for patients. So that's why I put it that way. So I could have divided it as oral medications and insulin and or injectables, so on and so forth, but I just wanted to do it this way. So the first, you look at it here, this is the older medication column and this is the newer medications. So the biguanides, this is the metformin. This is the most common medication we use. I'll talk about that in a little more in detail. That's usually the medication we start off with in most patients. The second group is the sulfonylurea group, and that group is the glipizide, glimepiride, and glyburide. And these are also very common medications which are used to treat diabetes. The third one is the Actos or Pioglitazone. It's sort of fallen out of favor, but I do still use it in some of my patients. The fourth one is the meglitinide group, which is there are two drugs here. We do use it sometimes, not that often. The fifth one is the acarbose or the alpha glucosidase. You don't need to know all the names. I'm just sort of putting it there. That's just to at least make you understand there are different groups. And this is used usually 3 times a day, and it's not that common we use this. And also I put in insulin because insulin has been there for almost like 80 years. And some of the newer insulins are there. I'll go over that also, but insulin, I put it there. The newer medications, these are the ones in this column in 2005 or later. So the DPP-4 inhibitor group, I'll talk about a little bit. The drugs which come in this group are Januvia, Onglyza, and then Tradjenta and Nesina. I'm giving you all the brand names because that is how we usually know them. I don't want to give you the generic names because it will become more complicated, and I'm sure some of the advertisements on the TV, things like that, also usually they advertise by the trade name. The GLP1 group, this is a group where these are injectables, but they are not insulin, and they are a very, very powerful group and very effective group to use instead of insulin, and I'll talk about that also. The other next group is, this is the most recent group which has come along. This is called the SGLT-2 group. This uses the kidneys. This group uses the kidneys to treat your diabetes. So the medications in this group are Invokana, Farxiga, Jardiance, and the newer one is called Steglatro. But it's a very, very useful group again for treating diabetes. And again, I said insulin and GLP-1 combinations, that also is one of the groups. I won't be talking about that much. And the last one is the Cycloset, which is also an older medication, but it is also helpful in treating diabetes. So metformin. So we usually, again, as I said, we start off with this medication in most patients because of 2 reasons. One is it's been, at least in US, I think it came in the 1990s, if I'm right, but in the other countries it was like in the 80s, and it's the most common medication used because it's a generic and it's very cheap. And the second reason is, if you don't use this medication, insurance will give you a problem to cover other medications. So we have to use this. Unless if the patients are not able to tolerate the medication, then we can say, yes, we can try and use the other medications, but most of the times we have to use this first medication. So the doses are 500 milligrams, 850 milligrams, or 1000 milligrams, and the maximum dose per day is 2000 milligrams. And there are the extended release versions also. It comes in 500 and 750 milligrams. Most of the times we tell patients to take it after they eat, after eating twice a day. You can start off with once a day. Like again, as I said in the next bullet point, you usually build up the dose due to the side effects. So what are the side effects? Most common ones are like having bloating, loose stools, diarrhea, those are the most common ones. So if you build up the dose from 500, maybe a week, next week you go to 1000, or maybe 10 days, after 10 days you go to 1000, after that you go to 1500, and then maybe the fourth week or something like that you go to 2000. That is if you're able to tolerate it. If you're not able to tolerate it, you go back to the dose where you were able to tolerate it. So the other means negatives are they are large pills, and the other good positive thing is weight neutral, because most medications with diabetes you gain weight. Okay, when you're treating diabetes, in most medications you gain weight, except for the newer medications. I'll talk about it as we go on. It works on the liver to produce less glucose when you're not eating. That's how it works. It works on the livers. It does not work on the pancreas. And also, the important thing with the metformin is when kidney functions are not that great, you have to be careful. You have to reduce the dose. Otherwise, you can have a condition called lactic acidosis. Basically, in that condition where the lactic acid builds up in the body, and you can have muscle aches, you can really feel tired, and sometimes you may even have to be admitted to the hospital. So as the kidney functions decrease, sometimes as we age, the kidney functions decrease itself, so we have to decrease the metformin dose, and at some point we may have to stop it. So the sulfonylurea group, this is the medications which I went over earlier. I just gave you a brief overview: glimepiride, glipizide, and glyburide. And the first one thing I didn't mention is, I did mention, I think, is metformin is generic, so it's not a problem. Means you can get, even if someone doesn't have insurance, they can get metformin for $4 at Walmart. It should not be a problem. So the sulfonylurea, all the drugs in this group are generics. So the glimepiride, glipizide, and glyburide are generic. It should be taken 5 to 10 minutes before you eat your meal. The reason is you want some time for the medications to work on the pancreas to produce insulin. That's the way it works. So if you're going to eat, you sort of, before you eat your meal, take it about 10 minutes before you eat your meal. And you don't want to give a long gap of half an hour or 45 minutes, because that usually can lead to low blood sugars. So 10 minutes is more than sufficient. Low sugars, again, the side effects, low sugars are the main concern side effects if not taken with meals. Weight gain can be a side effect in this group of medication. So you would want to use this group as less as possible so that patients don't tend to gain weight, especially if they're already overweight or obese. Need to be careful in elderly and when kidneys are not working well. Again, the reason for this is because of low blood sugars. And if you miss meals, or sometimes when kidney functions are not working well, the insulin stays in the system for a longer period of time, and you can cause low blood sugars. So this group, the meglitinide, it's very similar to the second one, the sulfonylurea group, but they are very short acting. They only work for 2 to 3 hours. Okay, the two drugs are the Prandin, which is a trade name, and Starlex, which is a trade name. And again, as I said, taken 5 to 10 minutes before meals. You have to, if you are eating 3 meals, you have to take it 3 times a day. So if you're only eating 2 meals, then 2 times a day, because it only works for 2 to 3 hours. So after that, it's not in your system. Usually 3 times a day with meals, and acts for only 2 to 3 hours. Low sugars again can be a side effect if you're not eating enough. These are generics, but they can be expensive because they're not as commonly used as the other drugs. So the companies which make, sometimes they definitely tend to price it higher, and sometimes you may need to get authorization and things like that. So this next group is the Actos or Pioglitazone. I won't go into what it is called. It's TZDs or Thiozolidinediones, that's what we call it, but just remember Actos or Pioglitazone. Usually is once a day, comes in 15, 30 or 45 milligrams. The usual dose we use is 15 or 30. 45 milligrams has fallen out of favor because of increased weight gain, leg edema, things like that. it acts on decreasing the insulin resistance. So basically when you give this, it basically helps the patient or the person's own insulin to be used more effectively. So that's a very good thing actually. So that's why I still use it in some of my patients who have insulin resistance, or I think that they have insulin resistance and I can use that, and in a lot of patients it does work and can cause weight gain and edema. Again, weight gain and edema which comes back again. And couple of important things here is it cannot be used if your heart function is not good. Someone has had a heart attack or some heart problems previously, the cardiologist would have done heart ultrasound called an echocardiogram. So you have to be careful in such patients, because if you're we call it ejection fraction, that is how effective your heart is pumping the blood, and if it is pumping less than 50%, okay, that's usually the normal is 50 to 60%. If you're pumping less than 50%, you should not use this. And one other thing which was a problem about few years, when I say a few years, it was probably more than 6-7 years ago, was there was a slight increased risk in bladder cancer with patients who were using this in a study done by Kaiser. But again, I think it was mainly overblown, but still most physicians are not using it. But again, some of the endocrinologists still use it because the way it works is helpful for the patients. This is the acarbose. It's very rarely used. Usually we use 3 times a day with meals. It's also the other trade name for this is Precose. The gastrointestinal side effects like gas and bloating are most prominent. So you have to take it with meals. So that's an issue. This is also a generic and readily available. Cost is not an issue. So the newer drugs, these are the ones which I said came after the year 2005. So the DPP-4 inhibitors, none are generic. So you just wanted to put it in the heading. None of them are generic. They're all brand name. The brand names are there: Januvia, Onglyza, Tradjenta, and Nesina. So all of them work on the pancreas indirectly to produce insulin. So basically when you're producing insulin, your sugar levels go down. And decrease glucagon. Glucagon is another hormone which is produced by the pancreas, but actually glucagon raises your blood sugars. So these drugs increase the insulin and decrease the glucagon. So if you're decreasing the glucagon, you're lowering your blood sugars. So all of them are once a day. They're weight neutral. So we keep coming back to this weight aspect. So that's the thing where we're treating diabetes, we always want to focus on the weight and help the patient with that also. Side effects are minimal and can be used in the elderly. None of them are generic, so can be expensive. And one of the rarer, the common side effects I would say is headache and nasal congestion. I've not put that there. One of the rarer side effect is inflammation of the pancreas. So you have to tell your patients that when you're taking this medication, if they get any bad abdominal pain, they need to stop the medication and call their doctor. So and that's what we usually tell our patients, that that if you have anything bad abdominal pain, then please call me, stop the medication and call me. So we can do some tests and see if it is inflammation of the pancreas or not. So these are the non-insulin injectables. They are not insulin, but they are still injections. So I have just grouped them into once a week on once or twice a day. So the once a week are the, you can say, more popular ones, because the twice a day, the Byetta which is there on this side here, we don't even use it anymore. I've not started a patient who's on Byetta for about 6 or 7 years right now. The once a day, I still use it. It's called Victoza. You probably have seen advertisements on the TV for this. The once a week is Trulicity, is Bydureon, and Ozempic. So how do these work? These work very similarly to the the previous one, the DPP4s. So what are they doing? These are GLP1. GLP stands for glucagon-like peptide, and that one, so it's GLP1. So basically these are hormones which were there in the patient before they became diabetic. But once they became diabetic, these hormones don't function as well or not in their system anymore that much. So you're reintroducing these hormones in patients to treat diabetes, and you're reintroducing these hormones at a much higher level. So they work on the pancreas same way indirectly to increase insulin production and decrease glucagon production. And also the other things which are positive about these drugs are makes a person feels full. So most of the times diabetics have a difficulty in curbing their appetite, eat less and things like that. So this helps them to do that. By slowing the gastric emptying, it empties your stomach slower. Usually diabetics have a faster emptying time. In this, it really slows your stomach down. And also acting on the brain makes you feel full, not to eat too much. Can cause weight loss, that's an additional positive. Some medications have been shown to reduce heart attacks and strokes. I've said some because some of them are approved for that and some are not. Nausea and vomiting are the most important side effects and usually occurs in the first few weeks when you start these medications. So you have to educate the patient. The first few weeks may be a little difficult for you. Please bear with us and call me if there is any issues. We'll talk to you and things like that. And that's what most patients are able to tolerate it. When I say most patients, I would say 85-90% of the patients are able to tolerate it. And again, it can cause inflammation of the pancreas, but it is rare again. It's not very common at all. The other side effect is there is a risk of a cancer called medullary cancer of the thyroid. But again, this was mainly in rats and mice. These medications have been there for almost 15 years as of now, or 14-15 years. And I have used in hundreds of my patients. I've not seen one cancer, but again, in rats and mice, they caused medullary cancer. So it is a warning on most of the longer acting medications, which is the once a week medications. It's a boxed warning. If you look at the box, when someone gets a prescription, it tells it can cause cancer in rats and mice. So the latest or the newer group is the SGLT-2 inhibitors. Again, here the GLP1 analogs, none of them are generic. So they will be expensive, but they are covered by most insurances, including the Medicare, Part D, and things like that. One or two of them are covered in most of the insurances. The SGLT2 inhibitors, again, here I say none of them are generic. The names which come under this group are Invokana, Farxiga, Jardiance, and Steglatro. They use kidneys to eliminate the sugar in the urine. So the way they act is they work on the kidneys, and instead of reabsorbing some of the glucose back into your bloodstream, they block that reabsorption and the glucose goes into the urine. It's taken once a day and then taken in the morning before breakfast usually. And since you are eliminating more glucose in the urine, you also eliminate water or fluid. So you need to drink more water. Infection of the private area, both in male and female, can be a side effect. So when we are educating patients about this medication, we make sure to tell them that you need to drink more water, keep the private area clean. And in men, if they've had circumcision, the chance of infection is less. In women, if they have had previous history of like fungal infections in the private area, things like that, they are at a higher risk. If they have not had it, there still is a risk, but they are at a lower risk. So again, in this group, a couple of the medications have been approved for preventing heart attacks and strokes and death due to heart problems. And one of them has been approved for preventing heart failure and admissions to the hospital because of heart failure. So Cycloset is a standalone drug by itself. It's not generic. It's used once a day. It's taken in the morning. You start with 1 tablet once a day, and every week you increase it. The maximum dose is 6 tablets per day, but usually most of my patients are able to tolerate 3 to 4 tablets per day, all at the same time. It works on the brain to help to use your insulin better. The most common side effects are headaches and dizziness, so that can sometimes limit the how much medication you take, the maximum dose of the medication you take. So when to use insulin? This was the other topic I was asked to talk on. Actually, there's no right answer for this. You can use it at any time. It all depends upon the patient and the physician. If the patients, I have a few patients who want to take insulin from the get-go, and they don't want to do that many medications because they've taken medications and they've had side effects with them, and they feel insulin is better. Okay, so they just take insulin like 3 times a day, and then their sugars are good or great. Most patients and physicians tend to try to use insulin later on in the disease state or process, but that may not be the right way. And if you have to start insulin earlier on, we can. So there are 2 types of insulin. One is the long-acting insulin, which is once a day most often. Short-acting insulin is mostly 3 times daily. So I just put up this table. If you look at that, the first column is the long-acting insulin. These are all the names here. You've more than likely heard of Lantus. There's Levemir. Toujeo is actually glargine, which is the component of Lantus itself, but it's like 3 times concentrated. So you're getting less volume of insulin but the same amount of units, like in less volume. Tresiba is also long-acting insulin. Both these insulins work up till almost like 30 hours, 36 hours. So if you take it once, it's not that you don't need to take it next day, you still have to, but they can work up to 30 hours. And NPH is the older insulin, which means we still use it sometimes, but not that often. So short-acting insulins are Novolog, Humalog. These are the Epidra, which we sometimes use in pumps and things like that. There's another newer insulin called Admelog. This is similar to the Humalog. They call these as biosimilar insulins. And there is Fiasp, which is similar to the Novolog. And there are mixed insulins. These are both long and short-acting insulins, which are mixed. We don't use these that often, but sometimes some patients we can use it. But most patients in this group, you have to be very consistent with your meals, like breakfast, lunch, and dinner. You can't miss meals because otherwise you will definitely have lows. Having low blood sugar, that's one of the side effects of insulin, which is definitely you need to educate patients about it, how to treat it, how to take care of themselves, what the symptoms are, everything. So next part I'll be talking about how often one should check their blood sugars. It again depends. Means a lot of patients don't check their blood sugars because sometimes you don't need to. Okay, if you are only on one medication and your A1C is like 6.8, 6.7 or 6.5 or even 7, you probably don't need to. But again, the reason we tell patients to check their sugars is we want them to learn how diet, exercise will affect your blood sugars, and also how they can change their blood sugars and so on and so forth. So it depends on what type of diabetes a patient has. Obviously, if you have type 1, as I said, it's insulin from the get-go. You may have to check 3 to 5 or even 6, 7 times a day. I have some patients who check it 8 to 10 times a day, and they want to do that and they're good at doing it. And how controlled the blood sugars are. If you're very well controlled, you probably don't need to check it that often. If you're not well controlled, then obviously if you want to get controlled, then you need to check it more often. Whether you are on oral medications or on insulin. So again, that's what I went over. So if you're on insulin more often, you need to check more often. If you're not on insulin, then maybe not that many times. So if you are on insulin, how often it should be checked? At least 2 to 3 times a day. Type 2 diabetics are on oral medications when not controlled, or taking mixed insulins 70-30 or 75-25, 50-50, we say 2 to 3 times a day. Important to check at different times. It's not like brushing teeth. When you get up in the morning, brush your teeth, like check your sugar and be done with it. You want to check it after eating maybe your lunch, before eating dinner, maybe before you go to bed. So that way we have a different different times you're checking the sugars. We know how your sugars are behaving at different times. So not just in the morning and be done with it. So if you have to check more, or 3 or 4 or more times a day, then type 2 diabetes, you're on more than one type of insulin. Type 1 diabetes, as I said, and when a patient is on a pump, that's where this is a device which you'll attach to your body, and every 3 days you have to change it, and your insulin goes into the subcutaneous tissue in the belly. So when the patient is on a pump, you have to check more than 3 or 4 times. And when the patients are uncontrolled, initially when I start off treating patients when they're uncontrolled, I tell them at least to check 2 to 4 times. So I just wanted to show this slide, because if you look at, if someone's A1C is more than 10, 70% of their blood sugar is being contributed by the fasting blood sugar. So if someone's A1C is more than 10, the most contribution is coming from the fasting blood sugar. So if you come around 9.2 to 8.5, it almost becomes equal, 55 and 45. If you're between 8.4 to 7.3, it's 50-50. So if you're less than 7.3, most of it is by your after meal sugars. Very little, only 30% is by your morning sugars. So it gets reversed. So here it's 70-30 here if you're more than 10, and if you're less than 7.3 here, this gets reversed. So it's very important. This is very important, and not only physicians, even patients should understand this, because for the reason, depending upon where your A1C is, you can tell the patients to check the sugars at what time. If my patient comes here less than 7.5, and let's say they were previously 6.6 or 6.8, and they had some issues, and now they're coming with the 7.2, 7.3, I will tell them, if they're checking in the morning, don't check in the morning. Try and check after eating. So that's very, very important for a patient where they want to get control. Again, blood sugars, taking the blood sugar monitor or logbook. Again, I encourage my patients to get the blood sugar monitor so that I can look at them, and I also can download them and show it to them, or both to the physician's office. Most monitors can be downloaded in the physician's office. Again, the physician's office should have the ability to do it, or they need to be set up to do it, I should say. Important to check at different times of the day. So this usually, if there is input from the patient, we can give you some output. So the output is, okay, change this, do that, or exercise more, eat less. If the input is greater, our output will be greater for you. If there is no input at all, it's like, I tell my patients, it's like a blind man shooting in the dark without the sugars. So you have to check to see, at least to get better control in the long run. Again, the other thing is, patient on insulin, the blood sugar acts as their story. So it's like watching still photographs versus watching a movie. So if you just show 4 or 5 photographs, that doesn't make a story. If I see like maybe 60 sugars in a month, that can make a story, or at least I can tell them do something different. So again, this is a patient, I just wanted to put this up. So this is a patient whose A1C is 7.9 here, but is only checking in the morning or every day in the morning, and all these sugars are great, or less than 130. So, but what is the problem here? So you go back to the slide. This is the problem. So the patient is somewhere between here and here. So that means they have to check after eating. So that is the important thing there. So again, this is a patient on two different types of insulin. He's having a long-acting and a short-acting insulin. So there are a lot of gaps here. No sugar, no sugar. There was 121 here, then a 343, got up high because he was high here. Again, no sugar, then again 343 here. So if we see this, it doesn't make that much sense to me. So you have to check more often again here too, or there are other options. I'll go into that a little bit right now. So this is pretty much the same. Yeah, this is the newer options. These are the sensors, okay, for diagnosing highs and lows. Basically, patients who are on insulin can more than likely or easily get it approved even for Medicare patients, but they need to be on insulin at least 3 to 4 shots a day, and they need to be checking at least 4 times a day for a month. Medicare will approve it. So what you do is, these are the sensors, and this is the latest one, which is called the Freestyle Libre, and you just put it on here or here, back of your arms. So, and that will give you the data. See these are the curves here for 14 days, and then after 14 days you take out one and put it on the other side. And when patients come here, we take this reader and then we attach it to the computer or sync it with the computer, and we download it. So we can get pretty much a 1 month's worth of the whole story of the patient, what the patient has done. So this is another one called the Dexcom. There are newer versions of this. It's a G5 and G6. I've just put the G4 picture here. It's very similar. It's not any different. But the latest one is this, and this is probably the cheapest one out there too, which is pretty much anyone can afford it. So this is a graph. It looks like, so if you look at it here, the patient, let's say he checked his blood sugar here. Again, he checked it here, checked it here, checked it here. So all these 3 sugars are great. This is slightly high, but you never know what went on here. So whether he had a big breakfast on a Sunday morning, we don't know what it was. So it went up almost to like 300 or 350. So that's why the importance of checking at different times comes into picture. So when you go to your physician, ask about your A1C. So why is the A1C important? It's a measure of your average blood sugar over the last 3 months. So it tells you a little bit of a story about you. Get your A1C checked at least twice a year if your sugars are controlled. Means if you're not controlled, probably more. I'll talk in the next slide. So A1C goal is less than 7, preferably less than 6.5. If the patients are above 65, 70 years, I would say 7 is fine. So what is the A1C? I wanted to explain what it is. Basically, A1C stands for hemoglobin A1C. We all know what hemoglobin is. It's basically a measure of your red blood cell content in the body. So this is the red blood cell. The red blood cells are coated with sugar. So if someone is diabetic and your sugars are not controlled, there is more coating over the last 90 days. The lifespan of the red cell is about 90 days. So the A1C gives you an average for about 90 days. So that's the simplest example I can give you. So if someone has like loss of blood or had surgery, then your A1C can be lower, but that is like spuriously low. Okay, so it's not like a real A1C. So how often to check your A1C? Usually every 3 months. Not controlled or adjusting medication. If you're controlled, then 3 months is fine. If you're not adjusting medications, 3 months is fine. Or every 4 to 6 months if stable and you're not adjusting medications. Yeah. So this is again, I wanted to show a picture here. So if your A1C is 5, your average glucose is 97. You're 6, you're 126. You're 7, 154. You're 10, it is 240. You're 12, it's 298. And if you're 14, it's 355. So this is in millimole. We don't need to go into that because that's where millimoles are used in Europe and other parts of the world. So the goals for sugar in the AM and before meals in the American Diabetes Association says less than 130, and the American Association of Clinical Endocrinologists less than 110. So after meals less than 180, the American Diabetes Association, and the American Association of Clinical Endocrinology says 140. So I usually, for my younger patients, and if they don't have any heart problems, other comorbidities, I usually use this. But if they do have anything, then this is more than acceptable, or even slightly higher than that is also acceptable. So again, all diabetics are not treated the same. This is, I just wanted to show you this slide is, if you are at higher risk for low blood sugars, things like that, then you can be less stringent. You can keep your A1C somewhere around here. So disease duration, if you've had diabetes for 45, 50 years, 30 years, then again you can keep your you can be less stringent. Life expectancy, let's say I had a patient today who was 93 years old and she takes insulin 4 times a day. So I don't want her sugars to be like 110 all the time or 100 all the time. I can allow her to go into the 200s or 220s or 230s once in a while, or sometimes. It's all right, because we don't want this patient to fall because of a low sugar and come into the hospital and get admitted to the hospital for about 5 days or whatever. So that's very important. So relevant comorbidities like kidney disease, heart disease, then you are okay with a higher sugar. If they don't have, you have to be more strict, more stringent. Vascular complications, that's what I said right now. And patient's attitude and expected treatment efforts. So if patients are highly motivated, yes. If they are less motivated, but we need to try and motivate them. But again, sometimes all patients are not the same. They're different, and sometimes as they say, right, you can only take horse to the water, you can't make it drink. So you try your best. And resources and support system. So also, if you are, let's say, here we have healthcare professionals everywhere. What if you're in a rural area and you're a type 1 diabetic and you're very brittle? So then you may want to keep your A1C a little bit higher. So the good news is, by managing ABCs, when I say ABC, A stands for A1C, B stands for blood pressure, and C stands for cholesterol. Those are the 3 ABCs of diabetes. And we also have D, which is diet, E for exercise, F for foot care. I think that was the talk I think it was about today, but we're not having that. So all these things, E for exercise and also eye care. So if you take care of your diabetes with all these things, I think most patients lead a very long life, and they may not die of complications of diabetes. So the ones which are most common are the steroids, like the prednisone. Sometimes patients takes them for like lung problems like asthma, COPD, things like that. And if they are on it for a long time, yes, definitely they can cause diabetes. And there are other medications which are used in psychiatry which tend to gain weight. So most of the time the albumin creatinine ratio is one of the things we check at least once a year. It is an independent risk factor for both kidney disease and also for heart attacks, strokes, and things like that. So patients who have a high albumin creatinine ratio, it could mean that you've had diabetes for some time, and at some points of time where you've not controlled your diabetes that well. That is one thing. Second thing is, it can also mean sometimes you have high blood pressure also along with the diabetes, and your blood pressure may not be well controlled. So in the long run, basically the blood sugar and the blood pressure are putting stress on the kidneys, and the kidneys, which is a filtering organ in the body, you are losing some protein in the urine. So the normal value is less than 30 usually, but if you're anything above that, then you have microalbuminuria. So if you're above 300, then we say you have macroalbuminuria. So in your case, you still have microalbuminuria, but as long as you control your blood sugar and blood pressure and take medications for that, there are medications like ACE inhibitors and ARBs, which you can take it and try and get the ratio lower. Edema is basically swelling of the feet. okay? So where your lower parts of the feet get swollen, okay? That is the term we use called edema. So some of the medications which I said is the Actos is one of the Pioglitazone. It can cause edema and sometimes even insulin can cause, when the blood sugars are really high and we start the patients on insulin, sometimes even insulin can cause edema. That means I don't think it should be at least taking the metformin before eating should not be that much of a big deal. The reason most of the times we tell patients to take metformin after you eat is because to lessen the chance of side effects. Because when you're taking it with the meal, right, it's not directly acting on the stomach, and most of side effects of metformin is again the gastrointestinal, which is gas and bloating and diarrhea and things like that. So as long as you take the glipizide or the glimepiride before eating, they work better. If you're taking it like 10-15 minutes after eating, let's say you took 15 minutes to eat and you're taking 10-15 minutes after eating, it's already half an hour is gone. So the medication does not have enough time to start acting. So it is important, and even the ones I told about, the SGLT-2 inhibitors, it is important to take it in the morning because the way they act. So because you don't want to take it in the afternoon or evening, because as I told, it makes you urinate more, and then you'll be up the whole evening or night to going to the restroom. So some of the medications, definitely we want it to be that way. And the insulin especially, when someone is eating and they're taking the insulin, it's very important to take it on time. When you tell patients, I have had a couple of my patients, it's not a lot of patients, maybe in my 14-15 years of experience, I've had about 3 or 4 where I've had to inform the DMV that they can't drive.
So you are mandated to inform?
Yeah, we are mandated, but again, it is very important that you build that rapport with the patient and let them know, look, if you're not taking care of yourself, if you don't check yourself, I have to probably inform, and then you will probably lose your license. Okay, so
they might suspend.
They once you inform the DMV, that's it, your license is gone. They'll send a letter immediately, and then they can try and get it reinstated. But then obviously, if as a physician, if I'm still seeing the patient, I will have to see them again and be happy with what they're doing, and then go from there. See, the most important thing there is checking your sugars before you drive, okay? And how often are you doing? As long as you're confident enough and things like that, you're checking your sugars, you're 120, 130, it's okay. But someone checks their sugar and they're like 75, then you probably want to eat something before you start driving.
What are the symptoms you feel?
So the low sugar symptoms are usually, you can have some jitteriness, you can have headaches, you can feel hungry, you can feel sweaty, you can have some feeling that your heart is racing. So these are all the symptoms of low sugars. We educate all patients for hypoglycemia because they need to know what it is, and especially if you're adjusting the medications, that's one of the things always we tell. So if you have low blood sugars, please cut this down, cut the other medication down, or make sure you eat on time and things like that. And also make sure that if you're going to exercise, get that into the picture. Okay, you are going to walk maybe 1.5 miles or 2 miles, which you usually don't do. So that also is very important. And the way you treat low blood sugars is usually we tell them to take like 15 grams of glucose. You get glucose tablets, which are like 4 grams, I think, each one of them. So you take 4 of them, which comes to about 16 grams, and then you ask them to check the blood sugar in about 15 minutes, and it should go up by at least 50 points. We usually call it the 15-15-50 rule. So 15 grams of carbohydrates, 15 minutes, and it goes up by 50 points. Your body has a metabolic memory. What I mean by that is it remembers. Even if it is for maybe 1 or 2 years, it remembers that, and then the damage is done. And again, we can't really find out how much damage is done during that time or anything like that. So for example, when patient comes initially as here was pointing about the albumin creatinine ratio. If their A1C is 9, 10, your albumin creatinine ratio can be very high. But once you control it, it comes back into the normal range. So, but again, if you have had diabetes for a long time and you have not controlled it on and off, that's the time where means some complications can happen and they don't come back into the normal range. Means you see what happens usually is if your blood sugars are so high, even if you go to the gym and work out, there are other hormones which are released, like your adrenaline or noradrenaline, and some of these hormones can actually raise your sugar, especially if you do anything like strength training, things like that, they can actually raise your sugar. So I don't see that anything being abnormal. So you definitely need to be on the medications what I sort of illustrated there, at least 1 or 2 of them, and you'll definitely do better. Okay, thank you. Thank you. Yeah.